Awesome. Thank you so much, Han. And before we dive into the content this morning or this afternoon, depending upon where you reside, man, I just want to say thank you to all of the participants, all of those that are carving time out of their schedule to come and learn more about those safety and risk concerns in regards to infants, children, and adolescents whenever parental cannabis is an issue. So y'all are working in this field, whether it's child welfare, substance use treatment, the courts, and the fact that you took time out of your busy schedule to learn more about this and to learn some of the practice considerations. I just want to again congratulate you for taking time out to become aware and to learn more about some strategies when it comes to improving outcomes for families that are affected by cannabis use. As my colleague Han was saying, this is session two of kind of a two-session webinar series that we have had around cannabis. The first session last week, you had an opportunity to hear from a national expert, Dr. Tori Metz, who really dove into a lot of the content, a lot of the research when it comes to prenatal and postpartum cannabis use. So again, I'm excited that series, if you registered and were able to attend that recording will be made available to you soon. But what we're going to do today is we're going to take a little bit of a turn, if you will. And what we want to do, one of the things that the Center for Children and Family Futures that we pride ourselves in is being able to gather experts from across the nation on a specific topic area. So you're going to get a chance today, not just to hear from us, but to hear from practitioners in the field across the nation, whether it be at the state or the county level, and get a chance to hear from them on some of the challenges that they're experiencing when it comes to serving families affected by parental cannabis use. And you're not just going to hear the challenges, but you're going to hear some of the ways that they've overcome those challenges and ways that they're implementing different practices and different processes to effectively serve families that are affected by parental cannabis use. So I'm super excited for the time that we have here today. Uh, Real quick, before we dive into the content, I want to take an opportunity just to introduce you to the panelists that we have here today. And as you can see, man, we have panelists representing both multiple different systems, different states, and different levels, be it state or county level. So I'm excited that we have Lindsay Barron, who is from the Vermont Department of Children and Families, and she is the policy and planning manager for the Department of Children and Families there in Vermont. We also have with us Vicki Ivies, who is from Nevada, and she is the Health Bureau Chief for the Nevada Division of Public and Behavioral Health, specifically the Bureau of Child, Family, and Community Wellness. And then we also have with us Dr. Edward Lau. And Dr. Lau is a pediatrician, and he currently serves as the medical director with LA, Los Angeles County Department of Children and Family Services. And then last but not least, we have with us Dr. Michelle Shepard, and she too is a pediatrician, and she is out of the University of Vermont Lerner College of Medicine. She's an assistant professor in that capacity. And then she is also with the University of Vermont Medical Center. So as you can see, we have multiple panelists representing different areas of the nation, different states, different jurisdictions. So our hope is through the time that we have together that you're going to get an opportunity to hear at a national level some practices and some practice considerations when it comes to serving families affected by parental cannabis use. But you're also going to get a chance to hear from these phenomenal panelists that we've been able to gather who have given of their time to speak into their work. And our hope is that you learn, again, what's happening in other areas of the nation, that you maybe find some commonalities with the work that you're doing, maybe some common challenges, but then more so that you also find some solutions and some different approaches and methods to improving outcomes for families that are affected by parental cannabis use. So again, we're super excited to have the panelists with us today. These are the three learning objectives that we hope to accomplish during our time together. First is we want to make sure that you gain knowledge on how other states and jurisdictions are serving both infants, children, and adolescents that are affected by parental cannabis use. We also want to bring awareness and help you gain knowledge and information around environmental safety and risk whenever parental cannabis use is at play. And then to really dive into some of those practice approaches and strategies for professionals from multiple systems, be they child welfare, legal professionals, substance use disorder treatment, medical professionals, those with expertise, or all of these different systems and subsets that are coming together to figure out how do we work with parents, caregivers, and family members that are using cannabis. So again, this is our hope that at the end of our time today that you will have gained knowledge in these three specific areas. Now, the way that our agenda is going to flow today is it's going to be a little bit different. A lot of times, if you've ever attended a panel discussion, there maybe is a little bit of content at the beginning, and then we follow it by a lengthy panel discussion. But what we want to do is we want to cover several different topics as it relates to parental cannabis use and again, its effects on safety and risk concerns for children and adolescents. And so we're going to cover the content, and then we're going to have points of panel discussion throughout that. Followed by, at the end, we're going to have a time for audience Q&A where we're going to get a chance to speak to a lot of the questions that you have whenever it comes to your jurisdiction and how you can better serve those that are affected by parental cannabis use. Now, one of the things that I wanted to make sure that I make you aware of is the Center for Children and Family Futures. We have created a 4-part tip sheet specifically around cannabis. And so I encourage you, if you've not had a chance to access these 4 tip sheets, there's going to be a link in the chat that will be provided for you to access these tip sheets. And really what they are is they're designed to equip professionals across multiple systems to both provide an overview of cannabis use, but really talk about and dive into its effects during the prenatal period, the home environment, and adolescent development. And in fact, we have seen with these 4 tip sheets that we have, I know we looked at some data last month, and these were some of the top downloaded resources from our site. So we know that you, the practitioners in the field, have a sense of urgency behind equipping yourself in this space. So I really encourage you, we're going to have a lot of discussion around some of these points during our time today, but these tip sheets really dive into a greater level of detail. So again, I encourage you, if you have not had a chance to access those tip sheets, please click on that link that was provided in the chat and make sure that you have a chance to download those tip sheets and use them to help you, again, improve outcomes for the families that you're serving. Now, what we would like to do is we want to hear from you, the audience. A lot of you, I'm looking, there are hundreds that are on this call today, on this webinar. And, we looked at the registration, and you're representing different levels. So we want to provide a space for you to speak into what are some of the aspects of parental cannabis use that you find create the most challenge in your work. So what you have seen posted in the chat is a link to a Mentimeter. If you'll do me a favor, if you'll click on that link, and it may prompt you for a code. And if it does, again, the code is 97136283. And what I would like you to do is, what are kind of 3 words that really encapsulate some of the challenges that you're experiencing? And so as I look here, I see, legality, that's always one that we find that comes up, children having access. We look at apathy. I know some people here have mentioned inconsistency or the physiological impacts. Again, we see legalization coming up, poor judgment, safety. I see the piece there in the chat, ignored because of the legality. Great. We're looking at acceptance, and I assume that's like social acceptance of cannabis use, safety. So I hope as you look at all of the different words and phrases from your fellow participants that are speaking into some of the challenges that they're facing, that you see some common themes between maybe what you're facing, whether again, like I say, safety, the access for children, neglect, the impact, and so on. And so our hope is that through our time together today, that we're going to be able to speak to some of those challenges, but not just speak to the challenges, but provide practical considerations regarding those challenges. And so what I would like to do is, I mentioned that we have this phenomenal panel today. And so what I would like to do is get their thoughts. What are some of the challenges or some of the issues that you're experiencing whenever it comes to working with families that are affected by parental cannabis use? So at this time, I know we have our panelists spotlighted here. So I would love to turn it over to you, and just feel free to speak into what are some of the challenges that your jurisdiction is facing.
I'm happy to lead off. Vicki from Nevada. On the systems level, I think implementation of plan of care and how cannabis inclusion is interpreted at a regional or hospital level has been an area with some challenges across the system, as well as when substance exposure is identified, but no referral is made by the hospital. So those are some areas that we're looking at in Nevada.
Yeah, no, I appreciate that. Others from Vermont or LA County want to chime in?
Hi, this is Ed Liao from Los Angeles. I'd just like to provide just a tiny bit of context for California. Back in 1996, medical cannabis became legal, and then in 2018, recreational cannabis became legal. And so the newer legal environment, I think, has been a difficulty for the community in terms of what to report to Child Protection Hotline. And I think the application of our policy where it's not the substance use or cannabis use that should be the nexus for an investigation or removal, but child safety, and that policy has not been consistently applied across when it comes to reporting to us. But the messaging is still that cannabis use in itself is the nexus to open a child investigation or referral case.
Mm-hmm. Yeah. No, I appreciate you bringing that up, Dr. Lau. And that's one of the things that we see in our work with multiple jurisdictions across the nation is we've seen some shift to not being substance specific in their reporting, but kind of like to your aspect is, how is child safety affected? How does it affect the ability to parent? But then it's like, once we see policy change, how does that migrate down to the practice level? How do we equip those practitioners to be able to live out that new policy? So I appreciate you speaking into how LA County is dealing with that. I'll turn it over to our panelists from Vermont to speak.
Yeah, I would say here in Vermont, we had slightly more on the delayed side as far as full legalization for recreational use of cannabis products. With that said, we were a little bit forward thinking in that process that we already had significant rates of reported use of cannabis prior to legalization status. So we made a policy change in 2017 that really helped clarify that cannabis use alone, just the actual use of that during pregnancy, was not going to be accepted for investigation unless, similar to what was just mentioned, there was concerns for child safety related to that or other substance use. I'd say for us, again, I think the issue was more the communication to the actual providers at the ground level, whether it was our obstetric colleagues or our midwifery colleagues, or even our pediatric and family medicine colleagues, that that was a trickle down to, you know, a change in practice from that kind of knee jerk of, oh, there's substance use, we need to make the call, to, oh, we have to think a little bit more carefully about this. Unfortunately, what can happen then is the swing to the opposite direction, where we went from knee-jerk calling all the time to, oh, this is not a big deal. We're just going to ignore it. Thanks for letting me know. Which then becomes a little bit of an issue if you are the pediatrician or social worker coming in at the time of birth to complete a plan of safe care for cannabis exposure, and the family has never heard of this and really feels blindsided. So I think that communication between the different teams that touch families always could use you know, some tweaks and improvements. And we practice a lot of continuous quality improvement here in Vermont, so we we definitely have been working on this for the last 8 years. So
Got you. Yeah, I appreciate that, Dr. Shepherd. And I think that speaks to a lot of times when we're working with states, and some of the feedback we hear from states is, again, what do we do again if there's prenatal cannabis use? And a lot of times we tell them first, like, learn what are the policies and practices within your state. First off, learn that piece there. But I like how you mentioned there's this need or this requirement to really equip and to get that communication down to the ground level on these policy changes. Because one of the things as participants and attendees that I want to make sure that we make clear is, a lot of times what you're doing as your states are maybe shifting from having a substance specific approach to really defining it by how it impacts the ability to parent and the safety of the child, is you're creating culture change, and culture change takes time. You know, and it's one of those deals, it takes time, and it also requires a cross systems response. You know, we say a lot of times that it's not a child welfare issue. It's not a substance use treatment issue. It's truly a community issue. And so in that context, it takes multiple systems coming together to figure out, how do we create this policy, but then more so, how do we translate that into practice across multiple systems? So again, I like that y'all brought that up, and I would totally agree, man. Vermont is definitely forward leaning in that space. So appreciate the work that y'all are doing.
I think one piece I might add to what Michelle shared is that perhaps what makes our practice strong and forward thinking sometimes comes with those unforeseen challenges, right? So, you know, I think back in 2017, when we did make this policy shift, that was really coming from both stakeholder and community advocacy, but also internal advocacy within our child protection staff, feeling like they were accepting reports. And, you know, having a child protection worker knock on your front door is can be scary. And our staff were feeling like there are no child safety concerns here. Maybe we're over intervening. Maybe this isn't the right balance. And so I think that perspective obviously has carried forward. And there's been such a normalization within our local culture around cannabis use. And so I think we now may be tipping slightly into well, it's just cannabis. And when there truly may be an underlying issue or a problem, we're finding that when we refer out for substance use assessment to figure out, what might be a good match for treatment services support, we're getting the answer back that there's no recommendations. And so I think our staff, along with the folks in the community that we're teaming with, we sometimes have to build ad hoc, processes or supports for folks, because there isn't a lot that exists specific for cannabis only. And so also revisiting the just cannabis, it's something that, across the workforce and with turnover, it's something to continually be paying attention to.
Mm-hmm. Got you. Yeah, I really appreciate you adding that context. And I think, that's what we find with a lot of states that have made that cultural shift, is like ensuring that the pendulum doesn't swing too far to the other way. And again, we really hone in on the safety piece and the parental capacity piece. So I appreciate you bringing that up. What I want to do now is I want to dive into the content. Again, we're here to talk about parental cannabis use, but I want to do so through the lens of these four areas of engagement: prenatal, postpartum and infancy, childhood, and adolescence. And so what I want to talk about first, and I know a lot of this was addressed in great detail during the first session, but I want to talk a little bit about that prenatal and postpartum cannabis use. And one of the things that the literature has suggested and speaks to is that that the cannabinoids do cross the placenta. And so we understand that there is that piece there, and that as a result of that, there are potential risks, including low birth rate, learning, and socio-emotional issues. And one of the things that ACOG, or the American College of Obstetricians and Gynecologists, and the American Academy of Pediatrics have done is they've made a recommendation that pregnant and nursing individuals should avoid marijuana use if at all possible. And I make a note here about marijuana is that's a specific term that whenever you see this within our slides, we put that there if the cited source specifically uses marijuana. But I want to bring to light that you see us really use cannabis, and that cannabis refers to all the products that come from the plant cannabis stevia. So we talked a little bit, and you had a chance to hear from the panelists how really they're focusing on when it comes to parental cannabis use around the safety and risk concerns. So I want to speak to that a little bit as it relates to infants whenever there is parental cannabis use. And based off the research, there's really four areas that I want to focus on in regards to safety and risk concerns. The first one is increased use. One of the things that studies have shown is that while substance use during pregnancy, it typically does decrease, usually in that postnatal period is where we see an increase of substance use. And so, again, that's one of those safety and risk concerns that we need to be mindful of when it comes to parental cannabis use, is understanding that while use may decrease during pregnancy, there are studies that suggest that it will increase during that postnatal period. Another safety and risk concern is secondhand marijuana or secondhand cannabis smoke. And as far as the risks for respiratory or sudden infant death syndrome, or SIDS. And then another safety or risk concern that the literature has found is around accidental suffocation. And we've seen through the literature that risks of accidental suffocation from co-sleeping increases tenfold for infants that are co-sleeping with a parent who is under the influence of substances. So that's one of the pieces that we want to keep in mind whenever it comes to parental cannabis use. And then, as many of you know, in the work that you're doing, the availability of edibles has significantly increased. So as a result of that, one of the safety or risk concerns that we've seen is accidental ingestion. If anybody, has kids or has had an infant at any time, that one of the ways they learn is through whatever they put in their mouth. And so, as a result of that, we see that accidental ingestion is a safety or risk concern. And in fact, infants are at a high risk for accidental ingestion since, again, they often put objects in their mouth. They put everything in their mouth. So again, here, when it comes to infants, these are really four safety or risk concerns that we encourage jurisdictions to keep in mind when it comes to infants who have a parent who is using cannabis. Now, one of the things that we have seen jurisdictions do is utilize this thing called a plan of safe care as a way of serving and improving outcomes for families that are affected by parental cannabis use. And when I talk about a plan of safe care, it's really grounded in this federal legislation, the Child Abuse Prevention and Treatment Act, or CAPTA. And basically, CAPTA in 2016, there was an additional amendment called the Comprehensive Addiction and Recovery Act. And it did a couple of things to the CAPTA legislation. And anybody who's had an opportunity to look at the CAPTA legislation, it is a big piece of legislation. I tell people all the time, like, man, the CAPTA legislation is so huge. that, and I don't know if y'all like reading legislation, but I could imagine almost like James Earl Jones, like reading CAPTA as like a sleep story on Calm. Like it is huge, but there is a specific portion of CAPTA that speaks to infants that are born prenatally exposed to substances. And within that piece of CAPTA, it talks about a plan of safe care. And then CARA, the Comprehensive Addiction and Recovery Act, it further refined the plan of safe care and said that it should be available to infants who are born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or FASD, fetal alcohol spectrum disorder. And one of the things that the CARA amendment did in 2016 is it removed the term illegal. So now we're not necessarily talking about legality. And I remember during this period is when the opioid epidemic was really at its peak. And so that was one of the responses that the legislature did is they removed that term illegal. So again, when we think about cannabis use and we think about the value that a plan of safe care can provide, again, it's not about legal, illegal. It's about, again, surrounding them with those supports and services that come through a plan of safe care. Also, what the plan of safe care does is when they made that change in 2016, they also said that it's not just for the infant, it's for the family. And it says it's for the infant and the affected family or caregiver. So again, we've seen a lot of jurisdictions, a lot of states use this plan of safe care as a tool to not necessarily become to shift from becoming reactive to taking a proactive approach to surrounding families that are affected by parental cannabis use with supports and services as far upstream as possible to, again, equip them with those services, get them connected to resources. So again, the plan of safe care we have found to be, or states have found to be an integral, a critical tool when it comes to serving families affected by prenatal cannabis use. And some of the considerations, if your states are currently implementing a plan of safe care, and though the term plan of safe care is used at the federal level, and that is the legislative language, in some of your jurisdictions, you may refer to it as a family wellness plan, or maybe a family care plan, or maybe even a family care portfolio. But again, the plan of safe care, one of the considerations to think through, if you're like, how can we use this tool to effectively serve families affected by parental cannabis use, is not minimizing those effects, not minimizing cannabis use or its effects, and understanding as you work with the family to develop that plan of safe care, helping to understand that while there may not be an immediate safety or risk concern, there are cannabis related risks, and ensuring that plan of safe care speaks to that and has those supports and services that connect them regarding parental cannabis. And also, again, around not minimizing cannabis use or its effects is understanding those potential risks include infants that are born with low birth weight, and that there's a potential for long-term effects such as memory and attention. And again, I would just say again that a lot of states, what they're doing is they're using this plan of safe care, especially in that prenatal space, making that available to families that are affected by parental cannabis use, and using it as a tool to bring multiple systems, multiple providers together to serve this family and connect them with as many resources and supports as possible. So I encourage you, if you're attending this webinar and you're not familiar with how is your state implementing the plan of safe care, are they using it for families affected by parental cannabis use? I encourage you to find out what your state is doing and get involved in that conversation and see how you can use that tool to improve outcomes for the families that you're serving. Now, again, we're still talking about parental cannabis use. What you see before you are practice considerations. So for our substance use treatment providers, really assessing for cannabis use disorder during those clinical assessments and supporting that plan of safe care development as well. Same thing for court professionals. Figure out how is the plan of safe care being used within your court practices, and how are you promoting the use of a coordinated approach between serving both the infants and the parents. And for our healthcare providers, man, screening is key. Like, how are we screening for cannabis use disorder, both during the prenatal phase and postpartum? And I would say not just a one-time screening, but how are you incorporating screening at multiple points throughout both the prenatal and postpartum phase? And then for healthcare providers, ensuring that you're connecting with those local substance use treatment organizations to be able to connect the families that you serve with care. So again, these are some practice considerations that you see specifically to that prenatal and postpartum period. And then what we want to do now is I want to give an opportunity for our panelists to question for our panelists to consider. And so if we could go to the next slide. All right, well, what I would like to do while we're transitioning over to the next slide for our panelists, I would love to hear from you. Like, what are your states doing whenever it comes? What are some things you've implemented around maybe screening during the prenatal and postpartum period for cannabis use? Maybe how are you using plans of safe care? And then maybe what are some practices that you put in place to ensure that rapid access to clinical SUD or substance use disorder treatment and assessment? And so let's start around screening. I think that would be a good place to start. What are some things that your sites, your states or counties have been doing around screening during the prenatal and postpartum period?
In Nevada, we've had a really large emphasis working through a perinatal health initiative on increasing the utilization of screening, brief intervention, referral to treatment, SBIRT work, including working with Medicaid to increase the number of provider types who can bill for SBIRT, just to try to really get a lot of resources, whether they're webinars, conferences, provider treatment guidelines for labor and delivery and postpartum, just trying to provide a lot of resources around educating on the importance of universal verbal screening and use of the SBIRT, as well as expanding reimbursement pathways for others to be able to do so.
Mm-hmm. I'm glad you brought up that reimbursement piece, Vicki, because that's one of the things that we've seen with other states too, is figuring out what reimbursement mechanisms are available for that screening piece. So I love that y'all have dived into that. And I also like one of the questions that we see a lot of times when we work with states or other jurisdictions is around screening versus toxicology. So I love that y'all put an emphasis on screening, specifically universal screening, because that is an ACOG recommendation. So I love that you're doing that in Nevada. Other panelists that would like to chime in on that piece.
I'm happy to chime in. We definitely in Vermont have been recommending for some time the use of a universal screening tool, and that can be verbal or paper-based or online. Ideally, one of the validated screening tools for use in reproductive age people, and even better if it's one that's specific for pregnancy. I would say this is still an area of improvement that we're working on. And we are currently engaged in the Alliance of Innovation in Maternal Health, or AIM initiative, the SUD bundle, or substance use bundle. And one of the things there that we're really trying to roll out is just better access to the different OB, family medicine and midwifery providers. Like, how do you even access some of these, proprietary tools that may cost money? We're not on a universal electronic health record here. So just kind of making available the screening tools we all think that are very important. Of course, with that, and I love that was kind of put out there as the first, is, what to do after you get a positive screen. And I think that is really where, our perinatal quality collaborative kind of brings together like the nurse managers and other engaged, community providers to say, okay, well, what do you do next? There's a pretty clear pathway for what to do if someone is suffering from opioid use disorder, and that gets a little bit more muddy when we're dealing with cannabis use disorder or even stimulant use disorder.
Yeah, that's good. I appreciate that, Dr. Shepherd. And I love you bringing up the Perinatal Quality Improvement Collaborative. And that's something that for our attendees, if you're not aware of the existence of something like that within your jurisdiction, I encourage you to research and find out, does something like that exist within your state? Because that oftentimes tends to be one of the key mechanisms or one of the critical collaboratives to helping to implement things like universal screening or helping to translate different practices around serving families affected by cannabis use. So definitely appreciate you bringing that up. Any other thoughts on this content here? Great. Awesome. Well, I appreciate your input there. I would make one particular note before we move on around plans of safe care. I believe there was a comment or a piece in the chat around Texas. And Renry, I actually happen to work with Texas, and being from Texas, I'm super passionate about their work. But Texas does have a plan of safe care, and they're actually in the process right now of figuring out how to better implement that during the prenatal space for both families affected by parental substance use, but then also families affected by specifically parental cannabis use as well. So definitely Texas is out there, and they are making it happen. So what I would like to do is transition a little bit to talking about those safety and risk concerns as it relates to children and adolescents, wherever parental cannabis use is a factor. And so one of the things that we see is that first, we know that cannabis use can affect cognitive functions. And so we think about through the lens of safety and risk concerns is when a parent's cognitive function decreases, it can directly affect their ability to meet their child's needs and to ensure safety and well-being. So there is a concern there. And then we go back to edibles as well. And it's a little bit different when it comes to infants, where it's like, they, sense everything and figure out the world through their mouths. Really, when it comes to cannabis edibles in this space, it's about access and availability. And what we're seeing is that cannabis edibles related poisonings, accidental overdoses, and trips to the ER among children from birth through age 12 have been steadily increasing. So how do we educate parents around that safety or risk concern? And then we've also found some of the literature has shown that there is a correlation between parental marijuana use and an increased risk of substance use by adolescents who are in the same household. So again, those are some of the safety or risk concerns that we see that are specific to children and adolescents whenever there is parental cannabis use. But let's talk a little bit about practice considerations. What are some things that you can do from the multiple systems that you represent to help inform, to help support, and to help improve outcomes for families that have children or adolescents in a home where there is parental cannabis use? First thing, man, our child welfare partners that build that parental protective capacity. That is one of the key things that you can do. And then also educate the parents on those safe sleep practices. Like, again, we mentioned even during the infant stage about co-sleeping. So let's educate the parents on those safe sleeping practices for children under one. For our substance use treatment providers, there are multiple promising practices that have been shown to benefit and to treat cannabis use disorder, be it CBT, cognitive behavioral therapy, contingency management, motivational interviewing. And I will say with the Center for Children and Family Futures, we have multiple resources on these pieces here on the value cognitive behavioral therapy, contingency management, and motivational interviewing. So I encourage you again to visit our site to check those out. And then also for our substance use treatment providers, develop that treatment plan that aligns with the child welfare case plans, their goals, and objectives. And I'll make a note here, when we bring up this practice consideration, that requires cross-systems collaboration. And I cannot stress enough, and I think all of our panelists that are on will speak to, again, just the value of working across systems to improve outcomes for families. So substance use treatment providers, working with child welfare, working with the court professionals, healthcare providers, all coming together to figure out how do we share information, how do we share resources, how do we share knowledge to effectively serve these families at a greater capacity. For our court professionals, implementing those collaborative court models, again, family treatment courts. One of the things the Center for Children and Family Futures is passionate about are family treatment courts and the value that they provide and the outcomes that are improved as a result of family treatment courts. So if you're not familiar with if your state or jurisdiction has family treatment courts, man, reach out to us. We would love to connect you with one of our partners and some of our colleagues that are involved in helping to implement effective family treatment courts. And then for healthcare providers, again, screening. I can't stress screening enough. If you've heard our panelists stress screening as well. Implementing universal screening for SUDs using a validated screening tool, be it 5 Ps, 4 Ps plus, UNCOPE, there are others, but figuring out how can you as healthcare providers implement that. So what I would like to do next is I want to open it up to the panel again. I want to let's talk about maybe how your states or communities, how are you responding to child welfare reports or cases wherever there is parental cannabis use, or maybe where child ingestion of cannabis or cannabis related products is a factor or an allegation. And some of you have talked about it a little earlier, but just want to give you an opportunity to maybe unpack it a little bit more or talk about, again, how your community is responding to those child welfare reports, because that tends to be one of the hot topics that we hear from multiple jurisdictions across the nation.
Hi, from LA County. Our policy and procedures don't specifically address infant or child ingestion of cannabis, but it is an issue of child safety. Parents should safeguard cannabis, and then the question arises how access occurred. We recently had a case or a call into child protection hotline about a 13-month-old toddler who had a seizure and was brought to the emergency department. His urine toxicology returned positive for THC or cannabis. And then the emergency department went ahead and called child protection hotline. And the worker provided a consultation, but did not progress the call to an emergency response or an investigation. The child then moved on into the inpatient ward, and then the pediatric resident physician called the situation again into the child protection hotline, and the second time the child protection services worker then moved the call to an emergency response to investigate. I think what was confusing to the first worker was that there wasn't any when the question was asked, is there a question of child neglect or child abuse? I believe the physician in the emergency department said no, or I don't know, and so that's why a consultation was given versus that movement to an investigation. So it's not specific, but again, it's still a child safety issue.
Mm-hmm. Well, that's good. I appreciate you unpacking that for us, Dr. Lau. Yeah, others that would like to chime in, maybe how their states or communities are responding to reports.
Something that might make Vermont a little bit unique is that we are a joint child protection and youth justice serving agency. So we tend to see sort of the full range of the spectrum of how there could be child and youth impact. And so a lot of concerns related to cannabis use are likely to be addressed more on the plan of safe care path. But when there are child safety concerns and an investigation or assessment is accepted, certainly a lot of the sort of context and information there is around, storage, access, what is within the home environment, what is the network of support, what does parent, use look like, and how to distinguish between recreation versus some other underlying misuse or perhaps underlying mental health coping strategies as well. We also see one of our greater challenges on the youth justice side is that, we're seeing youth who are driving under the influence or who are reporting, using, and incurring infractions. And the court system within itself is not well designed to have steep consequences there. And so we have youth who may be 16 years old and have multiple citations, and we're having to think outside the box in terms of how to wrap support around that youth and how to almost apply a harm reduction approach to understanding the impact, getting at the piece around, I know you may think you're invincible, but like let's try to get at the impact and the risks to yourself and others.
Mm-hmm. I love that. I like how you unpack that, Lindsay, and I think that speaks to not taking a punitive approach, but really taking a supportive approach of, again, how do we identify the underlying issues, and then how do we wrap you with the supports and services to really speak to that. So I appreciate you unpacking that for us. Any other panelists before we move on?
I just note on a public health side, trying to look at enhancing poison control reporting available to us to better understand the topic has been something that we're working on, as well as just sharing information, partnering with our Department of Taxation to have information both about pregnancy, breastfeeding, and child injury risk in all of the dispensaries statewide is another aspect that relates just on the public health side of the question.
Yeah. No, yeah, I really appreciate that. And I think, Vicki, you speak to the value of data as well, and just getting the data to really understand what the real issue is, and then making data informed decisions around that. So I appreciate that. Next, what I want to talk through is the risk of adolescent and young adult cannabis use. And what we're seeing is that cannabis is the most frequently used illegal drug during adolescence. And we find that studies have found that it affects decision-making, sequential memory, and impulse control ability. So couple that with the fact of like just being a young adult and just being a teenager, and imagine the impacts and the risk that's involved there. And then we've also found that one of the studies shows that developing brains such as those in babies, children, and teenagers are especially susceptible to the harmful effects of marijuana and THC. And so, as we see, there are multiple risks when it comes to adolescents and young adults when it comes to cannabis use. And one of the things that I wanted to point out as well is throughout this presentation and throughout our conversation today, you've heard me mention multiple studies or multiple different pieces of literature that speak to various components of parental cannabis use. And I just want you to know that what we have done is at the end of this deck, we have all of those references. So you're going to be able to go and dive into those studies and learn more about them. So I want to make sure to let you know that whenever you do receive this deck, at the end of the deck, along with multiple other resources, you're going to see the references for all of the studies that have been mentioned and cited during today's webinar. Now, again, back to the risk of adolescents and young adults. One of the things that we've seen is as cannabis accessibility has increased, there's a growing concern with youth perception of the risk of cannabis use. And I will say this is something I had the privilege of speaking at a national conference about 2 months ago. And we were talking about cannabis use. And this is one of the pieces, the social acceptance of cannabis, specifically for youth and young adults, that continually came up. And so that's something multiple states are seeing. Again, as accessibility has increased, the perception of risk has decreased with adolescents and young adults. And there's been a steady decline on the proportion of 12th graders who perceive regular cannabis use as a significant risk of harm. So again, that social acceptance has continued to rise, and it impacts both adolescents and young adults. And again, we know that where there is a lower perceived risk, there's a higher likelihood that a youth will use. With the resources, how do we equip families with the resources, with the education to raise that awareness of the effects of cannabis use, both with adolescents and with young adults. And I mentioned before that you're going to have access to the studies and to the resources that were cited. And this is a specific study that was done in 2014. And what it looked at is the frequency of cannabis use before the age of age 17, and how that frequency, what that looks like as far as adverse outcomes at age 30. And so what you can see here is the frequency of cannabis use, how it relates to whether it's cannabis dependence, other illicit drug use, or suicide attempts, again, before the age of 17. So as you can see, and of course, there's two bars that are like two shades of blue, and I'm partially colorblind, so like I really have to concentrate on this piece here. But as you see, like daily use has an impact on those three factors listed in that first graph there. But then fast forward and take a look, how does the frequency of cannabis use before the age of 17, how does it impact or affect adverse outcomes at the age of 30? So you see 4 outcomes listed there: high school completion, degree attainment, depression, and welfare dependence. And as you can see, the frequency of cannabis use affects all 3 of those adverse outcomes. So again, we know that it's there. We know that there is that the greater the frequency of cannabis use, the higher likelihood of those adverse outcomes, again, according to this study that was done in 2014. One of the other studies that we looked at was, again, around the risk of adolescent and young adult cannabis use, was around the prevalence of cannabis use disorder. And what this study did is it was done and it was published in the Journal of American Medicine in 2021. And it looked at the cigarettes or cannabis. And then it looked at the use disorder prevalence. And what it found is that when it comes to youth cannabis use disorder, the prevalence is double that of alcohol and other substance use disorders. And so again, we will definitely, this study is listed within the references. We'll make that available to you. But again, I think this is just another piece of data that communicates that risk and the need to really support families that have adolescents and young adults who may be using cannabis. Now, before we go into a lengthy time of Q&A, I want to spend some time talking about when it comes to engaging adolescents, leveraging the value of those with lived expertise. You know, and I think this is something that the Center for Children and Family Futures is greatly passionate about, is figuring out how can we work with sites to have them partner with and value those with lived expertise, because they provide they are an immense resource when it comes to not just youth, but I will say across the spectrum, you know, with families in general, having somebody who has walked that journey, partner with them along their recovery journey and help to, you know, establish a trusting relationship and in multiple other ways. So I would encourage you, as you think about the work that you're doing across multiple systems, be it child welfare, substance use treatment, the courts, healthcare providers, how are you using and leveraging those with lived expertise? Because they want to be a part of this process. They need to be a part of this process. You know, when we think about engagement, we think about service retention, when we think about all those different factors that play a part in connecting a family with treatment, leveraging those with lived expertise is a critical component to that. In fact, you know, many of the states that I work with, you know, they will tell you, one of the things that I often say is people with lived expertise have to be at the table. They have to be a part of whatever statewide or county response that you're creating to serve families affected by prenatal or parental cannabis use. Those with lived expertise have to be a part of developing that response. And not just developing that response, but executing and implementing that response as well. You know, I often tell sites, no matter how phenomenal our response may be, if those with lived expertise are not a part of it, it will never be what it could be. And so I love, and again, multiple sites we work with are doing just that. They're figuring out how to engage those with lived expertise. And the other piece that I'll point out about that is when we talk about engaging those with the lived expertise, whether it's specific to adolescents or the family in general, is one of the things that jurisdictions is how to meaningfully engage them. Are there compensation strategies for those with lived expertise? You know, a lot of us are being compensated for our time. Are there compensation strategies? Are there ways to, again, communicate that their voice has meaning? And the thing that I like is the Center for Children and Family Futures has created some phenomenal resources specifically around engaging those with lived expertise. And there are multiple jurisdictions that have taken advantage of that resource and implemented those practice considerations that are mentioned within the resource to really engage them at a higher level. So a couple of other pieces around engaging adolescents and just talking to youth. Again, I hit on this a little bit earlier, but it's super important to establish that trusting relationship. You know, so as providers, one of the things that I would encourage you, whether it's substance use treatment, whether it's child welfare, whether it maybe you're a part of a family treatment court, is I want you to figure out how are you establishing those trusting relationships and how are you intentionally established. Those don't just happen by accident. And when we look at phenomenal, jurisdictions and states, be they Vermont, LA County, Nevada, and others that are doing that, they're doing it in an intentional way, intentionally establishing trusting relationships. And then also it's about creating that environment for regular and open communication that involves both the parents, the caregivers, and other family members. So how are you doing that? And I would say, how are you doing that? Not just for substance use treatment providers, but for all systems. How are you creating that environment? And then how are you providing education and access to resources? And when it comes to access to resources and education, one of the things that I would suggest you consider is are the education and the resources appropriate to adolescents and youth? Are they in their language? Are they meaningful to them? Or are we, maybe handing them like a 20-page clinical document? It's like, that's not going to fly. So I would encourage you to think through, how are you providing education and how are you providing access to meaningful resources for the adolescent and youth population? So what I would like to do now, again, I wanted to open up to the panel again. And if you would just talk through, like, what are some of the challenges that maybe your state or county that you're experiencing regarding adolescent cannabis use? And then after you talk about that, maybe are there some ideas that either you have implemented or maybe you're considering implementing around those challenges that you've identified? I know one of the challenges that some jurisdictions have identified is, again, not just the increase in access, but the social acceptance. So I'm sorry, Dr. Shepherd, I saw you came off mute.
Oh, it's okay. I was going to say, I think throughout our state, again, we've always had high rates of substance use across the board in Vermont. And what we're seeing, unfortunately, when you look at the Youth Health Risk Behavior Survey specific to Vermont, a couple of concerning things, really, obviously, the overall use of cannabis continues to increase, and it's at least 30% of high school seniors. And then the concerning thing is really the perception of it being not a harmful substance. And I think that's where we really struggle, is that there's this general perception that it has so many great uses, and there are plenty of people purporting many, many good benefits. There are many parents that use substances. And so what we're seeing is this real substantive decline in any perception of risk, both for the adolescent themselves, but also in the way that they perceive their parents think about cannabis. And that, things like alcohol, people are like, oh yes, we understand that excessive use of alcohol is not a good thing. And that stays rather stable, but you're looking at the perceptions, both parental and adolescent perceptions, of it being a relatively safe substance to use. And we certainly have a pretty substantial access now. With both in Vermont, we have recreational use, as well as the ability of parents to grow their own. And so we do see a pretty significant number of families who it is part of their family culture that they grow their own plants and they make their own, different products. And so it really has become something that, unfortunately, the perception of harm is going down. And I would say also similarly, we're seeing a substantial increase in vape of nicotine, but also we're seeing many of our adolescents are coming in and are vaping cannabis products, which unfortunately they're buying online that may come with some other really significant risks that we don't know where the product is coming from or what's in the product, and have seen some downsides and some acute lung injury associated with that. And so, I think one of the things we've really worked hard to do here is just to make it something that our pediatricians and family practice providers just feel very comfortable talking about and demystifying. And my favorite thing to do is bring it up at age 11 and look at everybody's shock in the room and then say, we're going to talk about this every year because it's out there and it's not going anywhere. And I don't want to wait until someone talks to you about it at school. And the question is usually like, oh, how many people are vaping at school right now? And the family is like, that can't be happening in middle school. And I'm like, well, actually it is. So I think really empowering those people, both at the schools and in the primary care offices, ideally in school-based health clinics, if you have them, to really just start talking about it. And, other ideas are really, make sure you engage youth, like talk about people with lived experience. We're working hard to engage our youth and adolescent panels to really say, like, where are you getting your information from? Is it TikTok? Okay, maybe we need to counter TikTok with TikTok, right? So again, I think, we have to always be on our toes to keep up with how the message is changing and how they're getting to our adolescents.
Yeah, man, I love the way you unpack that, Dr. Shepherd. Man, there's so many like nuggets from what you said. I think it's important that, that attendees hear a couple of different things. First is like, where is their attention? Where is their attention, and how do we cut through the noise with, resources that speak to the risks, that speak to the concerns? So I love that you mentioned that. I love that you mentioned too, like making it a part of just the conversation that pediatricians and schools have with them. And I love that, like starting at age 11, and just making that a part of the yearly piece there. Again, making it more common to have the conversation, making it less scary, but then also, I hear like equipping the providers to have that conversation, because a lot of times, some of the things that we see when we work with different sites is, man, how do I have that conversation? What does that look like? And then also, and I know we mentioned this a little bit earlier, is, okay, if I have it and there's a need, what do I do then? So I love that you talked about, again, equipping the practitioner for multiple systems to have that conversation. That's good. Other panelists that would like to chime in around that.
Hi, from LA again. So I think a major challenge that our county has with youth in foster care using cannabis is that it jeopardizes their placement. No placement, short-term residential therapy programs, resource family homes, small family homes. They all have very little tolerance for cannabis or any other substance use. And so, many youth in foster care will then go AWOL to obtain cannabis or other substances, and then that again also jeopardizes their placement. And when you ask them, why are they using cannabis? A lot of them say that they're using it to calm themselves down, to basically self-medicate. And youth in foster care have a lot of history of trauma. And so it's no wonder that they would turn to cannabis. And so I think the system has to really think outside of the box to be able to address cannabis use. as you had mentioned, using peers or near peers with lived experience to address that. To begin with co-regulation of their emotions rather than just self-regulation off the bat. Art therapy, animal therapy, and I think athletics could play a larger part in treating youth with complex needs. And I think we have to. Most kids, I think, don't want to be in a therapist's office talking, and so we have to think outside the box for them.
Yeah. No, I love that, Dr. Lau. I'm glad you brought up that out of the box thinking, and then also figuring out how do we speak to the underlying issues. Like you said, some may be using it as a coping mechanism, or they say, or doing it to cope with whether it's trauma or other adverse experiences. And the question is, are our systems equipped for that? Speak to the underlying issues. So I really appreciate that. Other thoughts from the panelists? Awesome.
I think something that Vermont has done well, and there's probably opportunity to continue, is looking at this issue from the public health approach and raising it above a child protection or a child welfare issue. And so, even thinking about the launching of dispensaries and partnering around safe storage. So how are you keeping this safe from your kids, your dogs, anybody who's not supposed to have it? Let's give out lock bags so that everybody can, practice and have it safely in their home if they are choosing to do so. I think there's probably opportunity for even more public health campaigns and, sort of leaning in, like Michelle and others have suggested, into the social media platforms and TikTok and where youth are, and even like youth to youth generated content around it. I think there's some harm reduction that could occur in there as well. And then also just looking at laws that have been passed and efforts that have gone into place and addressing any inadvertent heightened risk that perhaps was created. And so, we often think about, there are dispensaries and there are safer sources for adults that does not exist for young people. And so the substance that youth may either have access to or may be seeking is actually much more dangerous than their adult counterparts. And so, purchasing things online, purchasing things sort of on the black market, it could be laced with fentanyl. It could have other substances in, which creates much more risks and challenges for young people. Whereas, for adults, or perhaps when they are just a year or two older, might have access to a safer source. And so how do you balance that as a state, as a society, and sort of plan around those realities?
Yeah. No, I love what you say. Yeah, again, just understanding the environment that we're in, jurisdictions, understanding the lay of the land, understanding how to effectively engage young people, how to use various outreach strategies as well. And that's the Center for Children and Family Futures. We have resources around outreach and engagement, but I think it's great to hear from you, the practitioners, just what that's looking like, real life, boots on the ground within your system. So I really appreciate you unpacking that for us. So I am looking at time. What we would like to do next is we would like to have a time. There's been some phenomenal questions that have been brought in. So I would love to turn it over to my colleague Han to just walk us through a time of audience.
Thanks, Sean. That was a very informative panel. Thank you all for participating in those discussions. So as Sean said, we're moving to the audience Q&A portion. We do have about 15 minutes for audience Q&A, so I do think we will be able to get through a good number of the questions that you have submitted via the Q&A box, as well as during the registration process. If we don't have enough time to respond to each of the questions that you may have submitted during this webinar, we will make sure that we respond individually to your questions via the email that you used to register for this webinar. So this first question, I think really resonates, particularly when Sean and Lindsay hit on the previous discussion in terms of are systems equipped to address some of the issues that were discussed during the panel, and then kind of how do we elevate it beyond just a child welfare issue to more of a public health approach? So the first question, perhaps our panelists from Vermont, Lindsay or Dr. Shepard, or maybe Vicky from Nevada could answer this. Could you share some prevention strategies or approaches that have been implemented in states or communities that have legalized cannabis use, particularly recreational use, or when there is a low perception of harm or risk?
I can lead off. I think a lot of efforts really gone into the messaging I mentioned earlier in partnership with other agencies, consumer facing messaging and on consumer focused platforms, safety messaging, embedding it in safe sleep curricula, just really trying to cross systems and as many angles to have non-stigmatizing, neutral, factual information going out in many ways to as many impacted audiences as we can, and working with a really broad range of partners and stakeholders.
Thanks, Vicky, for kind of reiterating those key points for me, which is, part of the public health approach is really the cross systems approach, the messaging, factual, and so forth. Thank you so much for that. Any thoughts from our other panelists?
Yeah, I was actually just going to mention exactly what Lindsay just put in the chat, which is that our Department of Family and Child Health has really taken substance use as one of the big initiatives that we work really heavily along all different cross-disciplinary regions, and we bring a lot of stakeholders to the table. But one of the larger public health messaging campaigns was called Let's Talk Cannabis, and it was launched and put out right around the time of, we knew recreational cannabis was coming down the pike. And so it was blasted everywhere, social media, it was all over the place. And what I appreciated about it is it took multiple different risk categories all at once. So again, our veterinary colleagues was like, let's talk about pets, because that's one way to get in the door of saying like, maybe we shouldn't leave our cannabis around. And then there was information about keeping it safe from your children and lock bags. Then there was information about driving and, pregnancy and breastfeeding. So it really hit all of those different topics and different consumers. And then we had a similar campaign that went out that was really for both our patients as well as for our providers. And that was called the One More Conversation campaign. And that was really geared towards people of reproductive age, people that were experiencing pregnancy or lactation. And that really was, trying to give people some information, but also really empowering people to talk to their healthcare providers about any concerns they had about substance use. And really, we put some questions and put some answers, but the real meat is talk to someone about it. Like, there may be other options we can recommend. There may be opportunities for treatment that we can provide. We can give you more information. We can point you in the right direction. And so I think, again, that public health approach of both prevention, engagement, communication, and then treatment if needed.
Thanks, Dr. Shepard. And then again, I'm thinking back to the great panelist discussion then Dr. Liao mentioned. What sticks out in my head is out of the box thinking, right? And then so Dr. Shepard and Baron, you really showed kind of how some of the approaches in your state, for me at least, because I come from a child welfare background, really represent out of the box thinking, right? Because first it's the outside of the box, and the messaging is not really just focused on one particular population who might be at risk. It really has messaging for all the different potential, as Dr. Shepard said, risk areas, and then it doesn't really focus on one particular population. And yet there's also a more focused messaging, focused on some of the potential risk issues specific to pregnant individuals and postpartum and so forth. All right, any other thoughts or commentary from other panelists before we move on to the next question? All right. Our next question, how has legalization of cannabis affected mandated reporting of cannabis use during pregnancy and by parents?
In Los Angeles, when it comes to plans of safe care and hospitals reporting, it's been inconsistent. You know, one hospital will report all cases of any substance use without really exploring the nexus with the child safety, and then another hospital will already have it in their policies and procedures, but that they will do a newborn assessment and really explore child safety before engaging in calling child protection hotline. So it's been haphazard. You know, here in California, the rollout of plans of safe care has been left up to the counties, and here in Los Angeles, it's been excruciatingly painful and slow.
Thank you. And then based on, some of our work with sites, I don't think LA County is alone in implementing these various pathways for affected families. And I'm sorry, I think somebody was about to chime in.
Oh, I was just gonna say, we are fortunate, we are a tiny state, so I always feel bad when I'm talking to much larger states, but we are so fortunate to have really good engagement with all of our community birth hospitals. So we were able to roll out a plan of safe care pretty early in the process and have been through revision cycles. I would say, I think the critical part for us is we developed a 2-tier pathway right from the beginning, where we basically said, in the absence of child safety concerns, the use of anything prescribed for pain, opioid use disorder, or anxiety, or use of cannabis was not considered something that would need to be reported to Child Protective Services for an investigation or assessment. So what that really did was it got it out there really early in the game. Like, are we talking safety or are we not talking safety? Can you start thinking about that before you make the call? If you're not talking safety, if everything else is going well, people are engaged in treatment, people have low risk use, they're using prescriptions as prescribed, that's going to go through a separate pathway. Now, we do still do a plan of safe care for that. However, that's done at the time of the birth hospital discharge, and we have a de-identified notification pathway. So although that information is collected for purposes of reporting to the Children's Bureau every year, it's not at all associated with any parental or infant information. And so that is not going into the pool of assessments. So that's a beautiful thing. Now, if child safety concerns, there's like 5 places of stop signs on our nice little flow chart, like any child safety concerns, like even if it's not substance use, child safety concerns, right? That's when you call, right? That's the mandated reporting. If you're worried about a child's safety, I don't care what it's for, please make the call. And we've been trying to really include alcohol in that as well. And I think that's been one area of still, like, it's very muddy in that situation. But I think having something that you can reference, even if it's just a flow chart that you made in Word, because maybe I did that, just to put out there so everybody can reference it and be on the same page.
Thanks, Dr. Shepherd. And then as a previous child welfare worker, I completely agree. Having something to reference is so important. And again, I'm thinking back to the panel discussion. I think there was some discussion whether it was about our states equipped to implement some of these policies and procedures. And then really, what does it look like at the field level? What are we asking our child welfare staff, our substance use treatment staff, our healthcare professional staff? We're asking them to carry out these policies, but what resources are we making available to them? Speaking of resources, Dr. Shepherd, thank you for sharing Vermont's kind of different pathways. I'm trying to stay away from the language differential pathways, the different pathways available to affected families. So just as a plug and for additional information, some of the materials that Sean described earlier on CAPTA, plans of safe care, and so forth. If you take a look at our website, we have lots of materials on plans of safe care, including various examples of how some states and other jurisdictions have implemented different pathways, including a notification pathway, kind of the more traditional child welfare pathway, and so forth. So take a look at those materials, and hopefully you will find them informative. All right, our next question, I'm going to take a look here. All right. How do we communicate with pregnant and parenting individuals about cannabis use in a non-adversarial way? I'll give our panelists a moment to kind of noodle on that. But again, if you participated in our first webinar in this series, towards the end of the webinar, our speaker, Dr. Metz, did provide some resources and some information in ways to engage pregnant individuals in these conversations.
I hate to talk a lot, but I would say I'm really passionate about bringing it up in the same way that people bring up everything else that you talk about in pregnancy. And you know, you're talking to people about their diet, you're talking to people about their exercise, you're talking to people about their sleep, you're telling them not to eat deli meat. Go ahead and ask them about which substances they're using and how much, right? I think it's just making it part of the discussion. And I think the hard part is, and I talk to a lot of people about this, don't make it a hand on the door conversation, right? Don't, as you're walking out, say, oh yeah, and by the way, are you smoking cannabis at all? That's not the way to bring it up, right? The way to bring it up is in the middle of the conversation when you're talking about everything else. You know, our role as healthcare providers is prevention and treatment, right? So we talk about, you know, ways to stay healthy when you're pregnant, you know, ways to manage symptoms when you're pregnant. And so I think it really comes down to, again, equipping your providers with that comfort level. It's practice and comfort level until, you know, and I always tell people, I'm like, providers, you got to fake it until you make it. You have to just keep doing it. You have to talk about it, and you have to just be like, okay, like, don't forget about the techniques that are out there. Don't forget about harm reduction and ESPRIT. You know, what are the potential, what do you see as potential benefits? What do you see as potential harms? Are there other things you've tried that were successful or not? And then just keep talking about it every time. I feel like people are well equipped to talk about cutting down tobacco use. And I think we just need to expand our comfort level out to, yeah, what would it look like if we cut back just a little bit? So yeah. Practice.
Yeah. And you know, Dr. Shepherd, one of the things that I would add to that as well, that we've seen with sites who have really increased that level of conversation happening at the practitioner level, is ensuring jurisdictions that you have a place to send them. You have a resource to provide them. It's a lot easier to have the conversation if I know what happens after a yes. You know, if it's like, well, I really don't know where to send you or where to refer you or what sources to give you, then I'm less likely to have that conversation. You know, so I think it's important as jurisdictions that you process through what resources are we giving, you know, healthcare practitioners to be able to connect them with care once they have that conversation.
Thanks. And again, I think a key takeaway that I have from this webinar is our theme that we've landed on is how are we equipping our systems and the staff that work within these systems to improve outcomes for affected families. And then I would further add to Sean's last comment about what resources are available for our healthcare providers, but by the same token, what resources are we offering to our child welfare workers when these conversations are had out in the field? And again, a plug, the center, we have a lot, we have in particular, I think our staff probably included it in the chat earlier on in the panel discussion. We have a recorded webinar on the NCOPE and specifically how child welfare workers can incorporate that into their practice and when working with families. So with that said, that brings us to the end of our audience discussion. Thank you very much.